Shall we start, Shalini?
Yes, ma'am. Good evening, all. I'm Dr. Shalini from Mehta's Multi-Specialty Hospitals. The moderator for the session is Dr. Lakshmi ma'am, Professor and HOD from Mehta's Multi-Specialty Hospitals. I would like to thank all my mentors, my seniors and colleagues for this wonderful opportunity. We are presenting a case regarding the antenatal drugs and their fetal consequences. How to proceed ahead with a caution. So, baby of X was born to a 31 years old G2A1 mother. She was booked and immunized and was a known case of Graves' disease, which she was diagnosed with 5 months pre-pregnancy. Initially, she was on propylthiouracil till 14 weeks of gestation, after which she was switched to methimazole. She was euthyroid prior to delivery. Her antenatal scans revealed a dating scan corresponding with her LMP. Her NT showed a value of 1.7 millimeters. Her anomaly scan done at 20 weeks of gestation revealed a single umbilical artery with the talipus of right foot. She presented to us with PPROM for 24 hours. There was no maternal fever, tachycardia, and her CRP was negative. She had received 2 doses of steroids and Maxelf and delivered a live male baby at 27 weeks with weight of 935 grams. Baby cried immediately after birth, received routine care and delivery room CPAP. His Apgar score was 7 by 10 and 8 by 10 at 1 and 5 minutes of life. And the baby was noted to have an umbilical cord hematoma. Hence, cord was clamped carefully and baby was shifted to NICU for further care. So this is the picture of the baby and with this umbilical cord hematoma. In NICU, the baby was managed for respiratory distress syndrome with 1 dose of surfactant given by INSURE technique. His FiO2 requirement had reduced to 21% by 4 hours of life. At 4 hours of life, baby had developed features suggestive of compensated shock, hence received inotropes of dobutamine and adrenaline, and his peripheral perfusion gradually improved by about 8 hours of life. So during the stay in NICU, we observed this prolapse of an intestinal loop into this umbilical cord, which was also found to be pulsating, or the peristalsis movement was evident, as seen in this video. So this was examphelos was diagnosed, and it was reviewed by the pediatric surgeon, and reduction and repair by laparotomy of the examphelos was planned after stabilization by 24 hours of life. In the intraoperative, the baby was found to have a terminal ileal atresia 70 cm from the DJ flexure with an absent terminal ileum, appendix and proximal colon, a narrow caliber microcolon with malrotation with Latz band across the second part of duodenum. So here is the intraoperative picture. As we can see, there is an microcaliber colon. And this was the size of the colon that was noted during the intraoperative period. The lat bands were divided and the colon was straightened out. End ileostomy was created along with the distal colonic mucus fistula in the left lumbar region. Postoperatively, baby was mechanically ventilated for 36 hours, followed by extubation to HFNC, which the baby tolerated well and received inotropic support in PRBC in view of the blood loss during the intraoperative period. Total parenteral nutrition was continued for the baby. Baby was kept nil per oral until day 6 of life in view of bilious aspirates and stoma yet to begin functioning. As the biliary aspirates ceased by day 6 of life, 1 ml of EBM was given, but following that, the baby developed abdominal distension. His girth increased by 1.5 centimeter. Hence, an X-ray abdomen was done, which showed pneumoperitoneum. So this is the picture of the baby taken during this deterioration. So baby was again taken up for laparotomy, and intraoperatively, baby was found to have a generalized biliary contamination. The stomach was distended but not perforated. A small perforation was noted at the jejno-ileal junction, as seen here by the demarcated by the box, and the bowel distal to the perforation was distended. Resection and anastomosis was done, and a glove drain was placed. Further, the baby was continued in mechanical ventilation for the next 48 hours. Feeds were gradually initiated by day 11 of life, and the stoma began functioning on day 15. Total parental nutrition was stopped by day 17, and by day 23 of life, we were able to establish full feeds. So during the discharge, right CTV was corrected by a Ponseti cast, and the attenders were taught and counseled about stomal care. Baby received NICU care for a total of 48 days for the other morbidities included, and was discharged weighing 1.810 kgs and on full Paladay feeds. So here we have seen a extreme preterm born at 27 weeks of gestation with a birth weight of 935 grams, whose mother was on antithyroid medications of propylthiouracil till 14 weeks of gestation, followed by methimazole, who had examphilos and CTEV and was found to have terminal ileal atresia and malrotation during the intraoperative period and developed pneumoperitoneum as a complication. So in this, we explored the literature regarding the possible role of the antithyroid medications and the spectrum of the birth defects that they cause. So in Valdez et al. Studied this methimazole embryopathy, and he contributed to defining the phenotype in addition to the usual embryopathy features that are mentioned. So in their study, they report of a neonate whose facial features included upward slanted palpebral fissures, arched and flared eyebrows, with a small nose with a broad bridge, in addition to the choanal atresia, esophageal atresia, and aplasia cutis, which is usually seen. In addition to Taylor Shaw et al. From US have reported of extra or rare combination of the congenital anomalies such as the H-type tracheoesophageal fistula, vitelline fistula, ruptured omphalocele, as well as multiple duplication cysts in addition to the usual features. So they attempted in reporting of rare combination of following features in their neonate. As we have known, we are aware of the methimazole and its spectrum of defects that it causes. So in this study done by Lauberg et al., he compiled all the studies that were that have reported methimazole exposure and the birth defects, and found that during the period of 6th to 10th gestation is when the maximum defects were noted if the mother was put on methimazole during that period. So far, what was thought was that methimazole exposure would result in a methimazole embryopathy, but what was considered safe was propylthiouracil because of the less severe nature of the birth defects. But this was proven wrong by this famous Danish study done on 8 lakh children, which explored the possible role of propylthiouracil in causing various defects. And as we can see here, the preauricular sinus and cyst and the face and neck cyst, in addition to the genitourinary malformations such as the hydronephrosis, developed even prior, that is around 5th to 7th period of 7th week of gestation. Even if the mother was exposed to propylthiouracil during as early as that period, so they were likely to develop these malformations. In adding to that, Leung et al. Reported of a case of neonate with congenital bands and intestinal malrotation after propylthiouracil exposure in early pregnancy. So what is this hyperthyroidism and why are we very concerned? It complicates only 0.1 to 1% of pregnancies, and Graves' disease accounts for more than 85% of the clinical hyperthyroidism. Antithyroid drugs are indicated only in treatment of moderate to severe hypothyroidism. So if this hyperthyroidism is poorly controlled and the mother is not compliant with her medications, she is likely to develop preeclampsia, placental abortion, spontaneous abortion, fetal demise, preterm delivery, IUGR, thyroid storm, and congestive heart failure. Propylthiouracil is the drug of choice during the first trimester because it is said to be associated with a less severe defects such as the face and neck cyst and urinary tract abnormalities, followed by a switch to methimazole during the second trimester because the propylthiouracil can cause liver dysfunction in the mother if continued beyond the first trimester. Both these propylthiouracil and methimazole crosses the placenta. Under the methimazole embryopathy, so far reported includes aplasia cutis congenita, tracheoesophageal fistula or esophageal atresia with the choanal atresia. Fetus is more sensitive than the mother to the medications. So even in therapeutic dose ranges of the mother, fetus can still get hypothyroidism and goiter. Hence, Whenever the mother is on medications, we should use the lowest possible dose and maintain her T4 in the high normal range and TSH in the low normal or a suppressed range. The other treatment options include beta blockers, thyroidectomy, and iodine. But beta blockers are useful only in controlling the hypermetabolic symptoms, and even then, their long term exposure can cause neonatal morbidities, including hypotension, bradycardia, and impaired response to hypoglycemia and growth restriction in the neonate. If thyroidectomy is necessary, it is safe to be performed in the second trimester rather than in the other trimesters because the risk to the fetus that time is higher. Iodine is contraindicated even at pharmacological dose because prolonged administration can cause fetal hypothyroidism and goiter. So to conclude, hyperthyroidism complicates only 0.1 to 1% of the pregnancies, but poorly controlled, it can affect both the fetus and the mother. Propylthiouracil is still the drug of choice during the first trimester of pregnancy. The methimazole embryopathy is well established and its spectrum of defects are known. Though considered as relatively safe, propylthiouracil is also associated with a range of defects which are to be explored further. Thank you.
Thank you, Shalini,
Thank you, ma'am.
for a very nice and crisp presentation. The main idea of taking this case for discussion is due to 2-3 things. One, we all go for extreme preterm deliveries. We all think about stabilization, respiratory, everything in the delivery room. We seldom give importance to a detailed examination of a cord and the presence of an omphalocele, which was missed initially because we thought it is a cord hematoma. So always take your time, even in the hurry. If you are clamping the cord, bringing the baby to the warmer to stabilize, have a look at the cord. If in doubt, leave a long length of cord and then ligate later after you're comfortable with it. And the second surprise we had is, okay, we thought we had missed a simple omphalocele, but when we opened, we saw very thin atretic ileum, no? It was just passing
Yes,
a 5-size feeding tube or so. That thin ileum was there. And the third thing is, we should always go back and find out the history. All this digging into the history happened much later. We were busy managing the baby and all that. Always the parents would want to know why, as to why it happened in my baby. So very detailed drug history, and as we started digging more, we got more literature proof of such and such a thing can still happen if the mother is on antithyroid drugs. So very, very important when you go into the antenatal history, take a very detailed drug history in the mother, whatever be the drug, and see if it has got any connection of the drug with the baby or the developing fetus. So that was the main idea of making us present. Though, despite being a 26-weeker, despite having 2 major laparotomy and such a very underdeveloped atretic ileum, this baby luckily responded very well and did very well with our management and went home happily. So that's why I wanted to bring it up in this forum. Thank you all for listening. Thank you, Shalini, for your nice
thank you, ma'am.
presentation.